All right, so we are going to go ahead and get started. I know folks are having some amazing conversations outside. They're going to be joining us back in. And now it's our third panel titled Synergistic Approaches in Climate, Health, and Equity Initiatives.
All right, well,
panel, this panel is going to explore the importance of cross-sector collaboration as well as the symbiotic strategies required in addressing the complex challenges posed by climate change and its impact on health. Moderating this panel is George Barrett. George serves as the co-chair of the NAM's Climate Action Collaborative to decarbonize the U.S. healthcare sector. George is also the founder of the Overtone Group and a previous chairman and CEO of Cardinal Health. So with that, George, I'll turn it over to you.
Thank you, Bashira. We'll probably have people sort of coming in as we go, so we'll just do the best we can to keep the doors closed. I had a very long opening remarks. That's not true. But we're running tight. I'll make sure I keep it short because we've got some fantastic leaders here who I want you to get a chance to hear. First, I do want to thank Kaiser and Climate Group and NAM for hosting this. It's been a really fantastic day thus far, and so I'm enjoying it. As always, I feel like I learn a ton from these and feel very much inspired by it. So I thank all of you for that. Just a couple of very quick comments about what I've heard this morning. I think it's just so many things jump out at me, but one of the things that I was struck by as we started talking about this as a movement and the reference to the quality movement. And, we talk about decarbonization, and it sounds very technical, but as we start talking about the human dimensions of this, it becomes increasingly powerful. And along this quality journey, I participated. I was a board member of an initiative to reduce safety events in children's hospitals is called the Solutions for Patient Safety. And at every meeting, we measured lives saved. And I was thinking back to a comment made earlier and how powerful that was. And that's the lens we need to keep in our head. That's the lens we need to keep in our head. So I very much appreciate the way this has been unfolding today. And also very much appreciate the notion that big bets or big challenges can only be addressed by having people with different perspectives and organizations with different perspectives, and I think we have that. This is an opportunity for us to take a little bit of what was talked about in the opening session, which was this idea of collaboration, and maybe work it down a level to a little more specificity. And before we get started, just one quick thing. We have a system that we all recognize, at least in the U.S. particularly, is fragmented in many ways, and yet it is completely interdependent. And I think that's one of the unique dynamics about it, is that the codependencies in our system are striking, and it's all the more reason that this work across the sector is extremely important. And so we have an opportunity to hear from some fantastic leaders here. And I'm going to introduce them in advance. Their bios are here in the materials that you have. But I want to introduce them, and then we'll get a chance to get to we've got Liz Fowler is here. Liz is the Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation of the Center of Medicare and Medicaid Services. Liz has been an incredible voice and action figure in this work. We've got Jonathan Perlin, President and CEO of the Joint Commission. You all know that the Joint Commission is critical in evaluation, assessment, education, accreditation. It's so important to our system. We've got Emmie, the Chief Program Officer at Healthcare Without Harm, one of the best named organizations I think we could possibly have, doing incredible work. Seema Wadhwa, who's Executive Director of Environmental Stewardship at Kaiser Permanente, and among the many people here from Kaiser who are exercising leadership. And then Renee Salas, who is the Founding Director of the Cooperative and co-coordinator of the New England Journal of Medicine's groups groups, Climate Crisis and Clinical Practice Initiative. And Renee, not just a clinician, but an educator and doing a lot of work to pull hospitals and systems into practice management and protocols and moving us on the right direction. So I welcome all of you. Thank you for your leadership. We are a group here, this group and many in the audience, of influencers. And I say that not in the context of social media, but in the context of human interaction. And so thank you for doing that. And with that, I'll turn it to you, Liz.
Thanks so much, George. And, you know, I'm so pleased to be part of the panel, really happy to be part of the Climate Action Summit today and join all of my exceptional panelists this afternoon. And so exciting about the Climate Grand Challenge. I was taken, Laura from the Lung Association started a remark saying she was sort of following on the inspirational leaders and going to talk about numbers. Well, I'm here to talk about Medicare payment policy, which is like one step below the numbers there. Just kidding, I'll try to make it interesting. So in my time here today, I just wanted to talk about a recent announcement that the CMS Innovation Center has made to tackle the biggest threats to our national and global health. Of course, that is climate change. You might ask why CMS's Innovation Center is stepping into climate change policy. We're an organization that was created to test new and innovative payment policies and payment and delivery system reform models within Medicare and Medicaid with the goal of improving quality and reducing costs. And why are we doing this? Well, the short answer is that climate change driven by greenhouse gas emissions threatens patients' health. And the efforts to address these impacts could both improve the quality of care and health outcomes for Medicare and Medicaid beneficiaries, and it also has the potential to reduce costs. So we think it is squarely within our mandate, and I should also add that as the Innovation Center, it's really our job and our responsibility to push the envelope and test new ideas. So with that in mind, 2 weeks ago, we proposed a new episode-based payment model to start in January 2026 called the Transforming Episode Accountability Model, or TEAM. Everything has to have an acronym at CMS, so we found a new one. Participating hospitals would be accountable for ensuring that people with Medicare receive coordinated, high-quality care during the procedure. We've identified 5 surgical procedures, and then the 30 days post-discharge. It's a mandatory model, so it's not a voluntary model. But along with that payment model, we've also proposed a voluntary decarbonization and resilience initiative that's comprised of 2 major elements. The first is a voluntary greenhouse gas emissions reporting system, and then second is an opportunity to receive technical assistance and learning system support for participants who undertake the decarbonization activities. I'll just briefly describe them before passing on to my fellow panelists. For the reporting system, we focused on 4 key data types: an organizational assessment, so questions like whether the hospital or health system has established an executive sustainability team, whether they've set decarbonization goals within the organization, whether they've implemented a decarbonization plan. Second, building energy and emissions. So using the Energy Star Portfolio Manager Program, hospitals would report Scope 1 and Scope 2 greenhouse gas emissions data, as well as Energy Star score and related data for their facilities, like energy use, energy source usage data, and energy use intensity. Some have asked why we stopped at Scope 1 and Scope 2 and didn't include Scope 3, and I think the short answer is we weren't sure what the reporting should look like. And so as part of the public comment period, we are asking for input on how we can standardize and collect that Scope 3 data in the future. Third is anesthetic gas emissions, and reporting here includes total emissions from inhaled anesthetic gases, anesthetic gas purchase records, questions about plans to lower use of desflurane, and then also decommissioning pipe nitrous oxide and substituting E-cylinders. And then finally, Scope 1 transportation emissions. And we would ask providers and facilities to create transportation emissions reduction plans and report on those plans to reduce their vehicle fleet emissions, gallons of fuel consumed in owned or leased vehicle fleet, and then plans to implement electric vehicle infrastructure. This is the first time that CMS has proposed to collect emissions data from providers and represents a really strong step forward in tackling the nation's, the health sector's carbon footprint. And importantly, in developing the proposal, the team, some of whom are here today, worked really hard to align the reporting requirements and with existing protocols and recommendations from industry and thought leaders, including, and maybe in particular, the Joint Commission, drawing heavily on Jonathan's work and the Joint Commission's work, borrowing expertise from OCHI, John Balbus and his team and their work, and then leadership from organizations like the UN Framework Convention on Climate Change and the Bipartisan Policy Center. We thought carefully about how to minimize reporting burden, and that's why we relied on EPA's Energy Star Portfolio Manager. This also marks maybe the beginning of what we hope will be a strong collaboration in the future between CMS and EPA on health sector emissions. For the model participants, and they will be mandatorily enrolled in the program, assuming that what we proposed goes into effect, but those who voluntarily choose to report the greenhouse gas emissions and all the other factors, we're preparing to share benchmark data that will help participants identify future opportunities to improve energy efficiency and really drive practice transformation that leads to more sustainable operations. We're also proposing to offer public recognition for voluntary reporting, maybe a badge on CMS's website, offering patients more information on provider quality, performance, et cetera. As part of the public comment period, we're asking for input on how to think about those incentives and also in the future potential for financial reward or incentives along with the program. The second element I mentioned in the program is the development and rollout of a technical assistance and learning systems support for participants, and that includes support for activities like accessing resources provided under the Inflation Reduction Act. We've heard a lot today about how difficult and complicated it is to access those funds, and so we would provide support for how to do that. Compiling and disseminating best practices from all the facilities who've really been very successful in lowering their emissions, and then identifying and disseminating tools to help facilities more accurately report their data through the initiative. Again, we're going to borrow heavily from John Balbus and his team as we think about providing this expertise. So the comment period is open until June 10th. If you need more information, you can find the rule, the proposed rule, as part of the FY 2025 inpatient prospective payment rule. And we really are asking, in fact, I wouldn't say begging, but we would really appreciate your input. This is a new area for us, and I think we really would like to rely on a lot of the help from folks in this room, just as we did when we were working on the proposal. And so just let me close by saying how excited we are about taking this step. And it's also worth noting that this proposal really is a direct result from the NAM's Climate Action Collaborative. And Dr. Zhao, good timing. I just want to thank you for your personal advocacy, because you were really what inspired us to take this step and to take action, along with others who helped inform our efforts. So we look forward to working with all of you as we finalize the proposal and explore new areas where the Innovation Center can propose a role in pushing the sector towards really a more sustainable and climate resilient future.
Thank you, Liz. Yeah, important step. So thanks for your leadership. John, I'm going to give the group a heads up. I know that you have a flight to catch, and so hopefully we will be able to have you for at least most of the session. So
terrific. Thank you so much. And Liz, what a terrific segue. When I speak on climate change, environmental sustainability, I often start with a question and a confession. The question is, how many of you spent your professional lives studying sustainability in healthcare? Confession, me neither. And
Well, there's a couple.
and there are a couple in here, to be sure. But a debt of gratitude to Victor, to the National Academies, to the terrific staff, to Kaiser Permanente, and Climate Action, Climate Group for your terrific work. And Liz, our work together on the policy finance metrics has been terrific, because what we've learned leads us to an impossibility, and that is you can't unring the bell. And with that knowledge, we felt compelled to make that part of our core set of principles to guide the Joint Commission under our current leadership. We call it our HELP agenda. It starts with health equity. It includes environmental sustainability, includes learning healthcare, the responsible use of health data for things like algorithms, and performance integration, which is really about making the process less performative and more fundamentally built into the operations of healthcare. And when Joint Commission was recruiting a new CEO, they said they wanted someone with senior government, health services research, and operations. And having been at the leadership of clinical activity in a large health system, I could not unring the bell on these particular topics, but the one I knew least about is the one that brings us all together here today, and that's environmental sustainability. You've heard from our colleagues what the health effects are, and really appreciate the work they've done to better understand this as an environmental justice issue, a social justice issue, a health equity, and because of resilience and not being there when communities need us most, a fundamental patient safety issue. Did you know that according to the T.S. Chan School of Public Health at Harvard, that 81% of primary care clinics were closed for at least one day in the last 3 years because of an extreme weather event directly related to the issue of climate change? And that means that fundamentally we're not meeting our mission of being there for patients when they need it. Now, I wish I could tell you when last year at this meeting we announced some potential new standards. I want to thank Jody Sherman and others for leading a technical advisory panel both to help us expunge things that might lead to overutilization on the one hand, but also suggest new standards on the other. They were met with a very cool reception. But as you heard, things changed. This past year galvanized worldwide that the effects of the environment on our health and well-being have made that a priority. From breathing smoke in Boston to New York to Washington, D.C. to Florida, west to Chicago, et cetera, from Canadian wildfires, and all the other things you've heard about, there was a new attention. And I'm pleased to say that by changing the focus and putting it on things that were operational in nature, like institutional resilience, operating efficiency, and let me just preface this recruitment and retention with, if you ask a healthcare operating executive today, what are their top 5 issues? It's workforce, finance, everything else. And recruitment and retention is absolutely critical. Thanks to the Commonwealth Fund, they published a study in January that showed that 79% of clinicians felt that their healthcare organizations should be doing more. And roughly equivalent numbers felt that they should personally be doing more, both at work and at home, in terms of supporting sustainability. So clinicians are heavily motivated, and let me assure you that it's rare that going on a survey that folks ask for more standards. This is one of the areas, particularly younger. And as evidence of that, the Robert Half Company did a survey. It found individuals between 18 and 34 do not want to work for organizations without an overt commitment to sustainability. So recruitment and retention is a very pragmatic approach. I hope Emily will talk about the channels of engagement because it's a way of reaching people where they live in terms of their immediate priorities, all with the same end, which is the reduction of carbon from healthcare. And the incentives of the Inflation Reduction Act are terrific. But you know, we heard earlier the power of the narrative. And when we talk about, the carbon footprint of healthcare, it's an abstraction. We talk about waste, for example, per 100 beds, about 1 ton or about 10 kilograms per patient per day. That's an abstraction. I want to briefly introduce you to my friend, a woman named Maria Koyek. She's Dutch, she's a nurse, she's a performance artist, she's a climate activist, breast cancer patient, but she humanized the story. She went, when she needed surgery for breast reconstruction, she asked her team, could I have the waste for my surgery? Now, just to assure you, there are some constants in the universe. In the Netherlands, the immediate response was, well, we need to check with the hospital lawyers first. But this is what she created through that, with homage to Da Vinci's Person in the Circle and the Square. You can see that there is roughly 45 feet diameter of waste from her surgery. Now, there are things in there you probably can't reuse again, like the gloves. There are things that, like forceps, that absolutely can be reprocessed. And there are things like gowns that absolutely can be substituted for launderable with absolutely no difference in infection rates. So we came forward with our sustainable healthcare. We ate our own medicine and signed the White House sector pledge to cut, and we made the advisory panels I noted before. And because Liz and I went to the same school of National Academy of Medicine Cooperative together, here are the components of our sustainable healthcare certification. Strategic plan approved by the board, a designated leader responsible for the operations, measure in at least 3 areas and convert to metric tons of carbon dioxide equivalents: combustible fuel, purchased energy, anesthetic gas, fleet vehicle fuel, waste disposal, meter dose inhaler, and make progress on this, share with your stakeholders, including your governance, rinse and repeat, and revise if goals not met. Now, I would tell you that we have international colleagues here as well, and you may not know the Joint Commission operates in 75 countries, and I really want to give a shout out to the International Hospital Federation, the Geneva Sustainability Center, Sonia Rushneck in particular. Together, we developed international standards, and we put those into the public domain. We've heard a lot today about the importance of standards, but having spent a lot of my career working on health IT, the old joke was, aren't standards wonderful? There's so many to choose from. Now, we need a standard, and that's why internationally it's one set of standards. I'm so pleased, Liz, that we could actually compare notes and work. Now, what are the benefits then pragmatically for achieving certification? Getting started on the journey. There are numerous support resources, including many of the organizations represented here, with whom we certainly owe a great deal of gratitude. Building those carbon accounting competencies, there's a library of carbon clinics from the national academies. Communicating stewardship of the environment, community, and workforce. It's both about meeting mission, but it's also pragmatic in terms of retaining that. Positioning your organization for financial incentives. The Ohio Hospital Association has virtually every hospital in the state aligned in evaluating energy so that they can take advantage of those incentives to recapitalize. Preparing for increased scrutiny, governance and government, and would also note that this certification is virtual. Program fees are modest. And a call out to the Meridian Hackensack Health System. They were the very first to be certified as a system. Today, we have about 80 hospitals and health systems certified, 270 in discussions, some exciting new programs to come. And internationally, one of the things that is impressed on my mind is the challenge of healthcare in the immediate wake of COVID. And I appreciate the distress. We lived through those challenges. But I want to tell you really quickly about the MP Shaw Hospital in Kenya. Dr. Tosif Dean has absolute circularity in basically a sustenance-level environment. And my goodness, if they can do it here, think about what we can do here. Thanks so much for all that you do. Thanks for those who've already signed up, and let's work together to actually move from concept to action. Thanks.
Thanks, John. Emmie.
Thank you so much. It's hard to follow these two, but it's just wonderful to be here with all of you today. And just to start, a thank you to Dr. Zhao, the whole NAM team, all of you for being here. It's really wonderful to convene this group of people. And as we're hearing, stuff is coming out of this, right? We're working together and seeing the imprints of that on our work. So I'm going to talk a little bit just to give kind of more of a framework and some specific examples of collaboration in the sector. Just to back up a little bit for those who might not be familiar with us, I'm here representing Healthcare Without Harm and Practice Green Health. We are an organization that's really looking to transform healthcare worldwide to really help the healthcare sector become a community anchor for sustainability, to lead the movement for environmental health and justice, and to reduce its environmental footprint. And then our Practice Green Health Network, I know many of you, Seema, lots of folks here today are part of our network. It's a group of more than 1,700 hospitals across the country, all working around sustainability. Hospitals in every state, every type of hospital, and then also allied partners who are other members of the value chain in the healthcare sector, folks like Johnson & Johnson and 3M and others. So I'm really glad to have lots of you in the room today and to have this network amplified really by NAM's work. So on the screen here is just a concept of climate smart healthcare, very similar to what we've been talking about, but just sort of a visual representation of this intersection between mitigation, resilience, leadership, and then at the heart of it is health equity. So I'll be talking a little bit about a particular example from each of these three pillars, if you will, of this climate smart healthcare concept, just to demonstrate the collaborations happening in this climate smart healthcare model. And one point just to sort of say, like, moving back, why collaboration? Why are we working together and collaborating? There was a really interesting report that recently came out in the New England Journal of Medicine, the Catalyst Insights report. This was authored by Kathy Gerwig and Dr. Lisa Patel, who I think is joining us virtually. But in that, it was a survey of the Insights members, and they named the top 3 barriers to why there's not more action in environmental sustainability. They're not going to surprise you, but I'll list them nevertheless. It's a lot of what John said: competing org priorities, right? Other priorities, namely workforce, other sorts of issues, financial barriers, and then the third, which I think is interesting, is a lack of measurement or support to really be able to have systems for measuring around environmental sustainability. And all 3 of those challenges, I think, are really only going to be able to be overcome by 2 pieces. One is us collaborating together, and the second is us integrating environmental sustainability into the work that healthcare is already leading. So we'll move to the first piece, which is mitigation. And in the mitigation space, this is just a handful of collaborative efforts. I'm sure we could go on, spend our whole hour talking about them, but just to spotlight a few. The one on the left here is a resource, a tool that we've produced at Practice Green Health, Healthcare Without Harm, and that is the Healthcare Emissions Impact Calculator. This is a resource for measuring emissions across scopes 1, 2, and 3. It is specific to the healthcare sector. It is it allows you to measure at both the facility and the system level, so you can roll up multiple facilities into a sort of large dashboard. It follows the Greenhouse Gas Protocol, the international standard for emissions measurement, and it's free, publicly available, able to be downloaded and used. And really, this is intended to reduce the barriers to entry for the healthcare sector. Folks who might not be able to, off the bat, hire a consulting firm to do their inventory for them, or kind of bring somebody from outside or from kind of the consulting space to do their measurement and their inventory. This is a great starting place. And then the second 2 pieces here are really honing in on the supply chain and focusing on the very big amount of the footprint that sits within the healthcare value chain. So this first piece, you'll see a QR code. I encourage you to pull your phone out, take a picture of it or download it, however that technology works. But really what it's a QR code. Clearly I'm not the social media influencer at the table. But what that will lead you to is this standard, and it's a collaborative effort because it was members of a healthcare climate council, so leading health systems from across the country working in partnership with a number of suppliers to develop one consistent standard that can be used to say, this is what good looks like in terms of supplier actions on climate. And that's important because we know that purchasers and folks are making different but similar requests and are being asked, they're asking suppliers for all kinds of different information that isn't consistent. So really important to see that kind of standard, to use John's phrase, in the supply chain. And then the third piece, I'm just going to give maybe a little hype woman. I won't go too much into detail, but I'll preview. Seema's going to share a lot more around this really exciting initiative, the CHARM work that brings together, again, that supplier health system collaboration with a roadmap for action-oriented near-term solutions for addressing emissions in the supply chain. Moving to resilience, I find this, I know we've talked about in a lot of different ways, stories have been impactful, statistics have been impactful. Here's one more that just really sits with me every time I think about what we've endured in this last year. Half of HHS declarations of emergency in this past year, in 2023, were related to climate or extreme weather. So half of the emergencies that we're dealing with are related to climate or extreme weather. I think that just hits home in terms of the importance of resilience, healthcare climate resilience, in thinking about how climate change is impacting readiness, patient safety, ability to provide continuity of care. We've talked a lot about the health impacts of climate change. I won't go through those, but what I will just point folks to is really thinking about a holistic definition of what it looks like to be resilient. On the left here, you'll see there's in kind of our sort of framing of it, 3 really critical components of resilience. Yes, it's about that facility resilience, making sure that hospital is able to, keep the lights on, continue to provide care, but it is also about public infrastructure resilience. Are those roads accessible, or have they been flooded out? Are the public utilities still accessible to that hospital? And then third, and critically, in fact, most important, is really thinking about community resilience as well. How are we moving upstream to really address the social determinants of health? And before disaster even strikes, or before air pollution gets worse, we're ensuring that community members are resilient to the impacts coming down the line. On the right-hand side, you'll just see a handful of publications, resources around climate resilience. One kind of bright spot I want to lift up is just that we have had, through the great work of Ochi and John and his team, the HHS Health Sector Climate Pledge. And through that, there's a component around developing a resilience plan. And we know that more than 900 hospitals have committed to that pledge. It's been wonderful to see how that has spurred action in terms of healthcare, developing these robust resilience plans that are kind of prompting these conversations. We led last year a cohort of more than 50 hospitals and walked them through in a peer-to-peer model, actually developing a resilience plan, many for the very first time, that integrates all 3 of these components, moving beyond, yes, emergency preparedness, but into a greater understanding of what resilience really means and looks like. And then the final piece under this leadership pillar that I'll just flag is that, a lot of the solutions are out there, right? There's a lot of learnings, case studies, examples. We have, again, in partnership with our Healthcare Climate Council, a playbook that has these wonderful vignettes, very data-driven, talks about kind of the emissions saved, the money saved, all of these kind of data points. And we added 13 new vignettes to this playbook. So I encourage you to check it out. It has really rich examples and gives place to start in terms of taking action on climate in the healthcare sector. And then talking about globally, I know we brought some global examples here. We convened healthcare facilities from across 17 different countries to develop 38 case studies, a combination of videos, written case studies, blog posts. So now we're taking learnings not just within the US, but what can we learn from other countries and what they're doing around healthcare climate action. So we know that the will is there. Where can you get started and where does this live? I love this kind of graphic, and this is where I'll close, just to sort of say there's lots of places where you could kind of think about a traditional hospital and hone in on, the food systems, or you could hone in on the OR, or you could hone in on all these different pieces. It's yes, honing in on all of these pieces, but also seeing the bigger picture. And I'm grateful to NAM because I think them convening us in this way has allowed all of us to collectively take this important zoom out, break down some of these silos within the hospital that we know are existing, and just kind of connect those dots together. So that's where I'll end and pass it off to Seema.
That's great. Thank you. Seema, we're turning it to you.
Great. Well, thank you. How lucky am I to be on a panel with such amazing leaders? And I wanted to take a moment to thank our partners from NAM and from the Climate Group who helped really bring this concept of a Climate and Health Day to a reality. And I'm just so thrilled to have so much excitement in the room today. So you've heard about so many impactful speakers about the different ways we can engage. And what I'm here to talk about a little bit is, what does that action look like? John Balbus mentioned the train, and we're on the train. So what does it look like when we move the train, and how have we done that through radical collaboration? So as the nation's largest integrated health system, we've been on a multi-decade journey to focus on addressing the health implications that stem from climate and the environment. And, we do this because we see firsthand, as you heard from my colleague, Dr. Weil, what it means to our communities and to our patients and to our team members when climate and environment come knocking at our door. So, with that, we address how we manage our environmental stewardship in 3 key areas. The first one focused on our sustainable operations, the work we do to manage our own footprint. The second one is a focus on supporting our members. How are we preparing and supporting our members in the face of those extreme heat days, in the face of the climate challenges that they're dealing, whether they're wildfire or vector-borne diseases? And the third one relates to how are we supporting our communities and helping them become more resilient to these challenges. So I'm going to spend a little bit more time talking about our work around our sustainable operations. When it comes to our sustainable operations, we've been on a very long journey, and when it comes to our emissions, in 2016, we set an ambitious goal to become carbon neutral. And at the time, it was a bit of a moonshot. We knew that it was potentially feasible. It was going to take a lot of work, and it was going to take all of us. But I'm very proud to say that in 2020, Kaiser Permanente was the first large health system to achieve certified carbon neutral. And, with that really set us up for a path of understanding what our Scope 1 and our Scope 2 really looked like. And, along that also meant large investments in wind, in solar. We're the 8th largest user of solar energy in the country, 100%, a renewable energy right now. But from that, we knew that there was still more for us to do. So we started on a path to do an emission inventory of the rest of our scopes, so Scope 3. And on that journey, we realized that while we have addressed our Scope 1 and Scope 2, there's still a lot of work when it comes to Scope 3. And it's the type of work, especially in the supply chain, that is complex and complicated, and work that really needed to leverage radical collaboration, as well as work that required coming together to be collectively working on this effort. So, let's rewind a couple years ago. I was at Clean Med, and I was joining one of my colleagues here, Errol, for a barbecue, and we were thinking about the fact that there really wasn't a table that was set for us to work together. While we're very fortunate to have the Healthcare Climate Council that brings together health systems, there was no place for us to work with our suppliers on the biggest challenge of our time, decarbonization. So we said, you know what? This is something that we can do something about. And, later that year, for a period of a year, we convened, along with Healthcare Without Harm, a series of 3 roundtables. We pulled together 20 of the largest health systems alongside with about 20 of the largest suppliers, collective suppliers, and we did some deep work to really identify what are the collective areas of action that we can work on and that we can accomplish in a short period of time. So we developed a 24-month actionable roadmap that focused on 4 key areas: renewable energy, product innovation, product utilization, leveraging clinical engagement, and transportation and logistics. And within each of those categories, we identified specific actions that both the suppliers and the health systems believed would be more effective for us working together. And, I'm excited to share that earlier this month, we launched that collaborative in partnership with Vizient as our co-chair, and that collaborative is being managed by the Sustainable Purchasing Leadership Council and supported through many others. And, over the next 24 months, we will be actioning on these identified areas. We currently have 14 members, as well as another 10 that are just about ready to sign up, and that's from launching just a few weeks ago. And, the thing that excites me most about this is that we know that there is a pathway. We know, as large as we are as Kaiser Permanente, that we can't do it alone. But we see that others want to join us on this journey. And in terms of having hope, that's what gives me hope. That's what makes me know and believe that there is a way that we will be able to solve it. And that way to move that train forward is to collectively get on the ride together. So thank you.
See, influencers. That's great, Seema, thanks. Renee.
Well, first off, it's an honor to be here, and thank you to the National Academy of Medicine and Kaiser and the Climate Group for bringing us together. And to speak along my esteemed colleagues, I am inspired down here and excited. So, as you've heard, the very act of caring for our patients produces greenhouse gases that drives climate change, that then harms our patients and makes it harder for us as clinicians and health systems to do our job. So, complementary to healthcare decarbonization efforts, there's also an urgent need to better prepare and equip clinicians and health systems to protect their patients and communities from the harms that are being experienced right now in exam rooms across the country. For example, I cared for a young girl that presented for an asthma attack, and it was her third visit that week. As her small chest was heaving up and down, we gave her medications to help stabilize her breathing. And the mother's voice broke as she recounted the countless hospital admissions and home treatments. And she said to me, I am doing everything that the doctors have asked me to do, and she just keeps getting worse. What am I missing? Well, that led me on my own journey to more deeply discover what I was missing. My patient received the treatment she needed to leave the hospital, but she was still going home and breathing the same polluted air that was making it impossible for her to manage her disease, and she wasn't alone. And the air is filled with not only the pollutants of burning fossil fuels, but also climate-intensified harms, like intensified and higher pollen levels, and wildfire smoke that spreads across the country. So the treatments I provided her were not actually getting to the root causes. What my patient needed was a home air filtration system and weatherization to keep that purified air within her home. And ultimately, what she needed was a transition away from fossil fuels, so that way her neighborhood was no longer polluted. But our medical toolbox doesn't have those tools. I'll highlight 4 gaps. First, we need a way to identify high-risk patients easily. Second, we need data-informed guidelines that outline the strategies for all the things that we need to think about when caring for that patient in front of us, and it has to be integrated into our existing workflows. So, for example, should I have recommended that my patient, a 4-year-old, wear an N95 mask if she had to go outside on a poor air quality day? The guidelines and data isn't clear. And third, we need pathways to get our patients these solutions and interventions that they need, like home air filtration systems. And fourth, beyond the data that I need and we need to guide the patient sitting in front of us, we also need the data to make the compelling case to stakeholders like health insurance companies and policymakers and health systems to invest in these strategies that are to get our patients what they need to be protected from climate change. And so these are needs increasingly being felt by clinicians and health systems as climate change intensifies. To again cite the New England Journal of Medicine Catalyst, they did a survey and included nearly 500 US healthcare organizations, and over 90% recognized that climate change was impacting their patients, and 70% that it was impacting their delivery of care. And the number one thing that respondents said they needed in order to be resilient was data on climate change-related health impacts. So there's a new national endeavor that I'm leading called the Cooperative that aims to fill these gaps by driving climate-informed clinical practice in healthcare delivery. The Cooperative will comprehensively understand how climate change is impacting clinical practice and the delivery of care, determine what can be done to prepare and improve it, and work with partners to make it happen. I'll give a brief preview of the Cooperative scope of work and approach. So first, our scope. We'll create clinical practice guidelines by medical specialty, tools to help implement them, and data to guide and evaluate interventions. But first, we're going to re-examine our assumptions and rethink the way things are done as needed. So to do this, we'll generate a holistic understanding at different local sites around the country to understand the commonalities, the differences, and the disparities. So for example, what are the exact ways that climate change is harming a patient's health or impacting a clinician's practice or a health system's performance? Which interventions currently being used work well and which don't? What are the barriers and what are solutions, new solutions are needed? Second, our approach. So serving our partners, the Cooperative, true to our name, will collaboratively achieve this mission through a national network of experts and change-making organizations structured around local innovation hubs. Our local innovation hubs are partnerships among local healthcare systems, public health entities, government bodies, community organizations, academic institutions, and more. Locally, they commit to tackle the climate crisis together, while also working closely with other hubs around the country to share and evaluate experiences so we can quickly learn what is working well and what isn't. And local innovation hubs will center community organizations, especially those on the front lines of health disparities from racism and income inequality, so that way to ensure that their needs and experiences drive the guidelines, tools, and data. Our inaugural local innovation hub is in Greater Boston and is anchored by the home institution of the Cooperative, Massachusetts General Hospital, with more forthcoming. And our diverse national network includes founding partner organizations like the New England Journal of Medicine Group, the National Academy of Medicine, and we're very grateful to Dr. Zhao and his team for their continued support, the American Public Health Association, and thank you to Dr. Benjamin and his team, and the Lancet Countdown. So this national network is building off our existing collaborative efforts that include the Climate Crisis and Clinical Practice Initiative with the New England Journal of Medicine Group and the Lancet Countdown US Brief Working Group. So collectively, we aim to improve health outcomes and resilience to climate change for all patients, but we have a focus on those who are disproportionately impacted. The responses needed to protect patients from climate change are interwoven with the social determinants of health, which provides an opportunity for other interconnected benefits. And we can help make climate action and decarbonization personal by connecting it to the health of patients and the very job and mission of clinicians and health systems. So in closing, I bring us back to my patient. I could respond to the mother's plea in that moment, and it still haunts me. But the Cooperative can, as it organizes and coordinates a collective response, one that integrates the creation of guidelines, tools, and data across a local to national collaborative network of partners, centering the needs of those that are most impacted. Because together, we can ensure that young girls like her and so many more are protected. But we have to do this together, and so I hope you join us. Thank you for your time, and I look forward to our discussion.
Renee, thank you. We have tried hard to stay on time here. We probably have time for one question from the audience in the room, and maybe take one from the folks on the line.
Hi, I'm Ben Fulencio Turner. Good afternoon from Eco America. So I'm really compelled by those surveys finding such high percentages of healthcare workers both seeing the crisis affecting them, seen as a priority, wanting their institutions to do more, and all of these incredible partnerships that really come from institutional or national leadership. So my question for you all is, what can the individual health practitioner do on the ground to drive these changes either within their institution or more broadly? Kind of what do you think is most impactful?
I'd like to take that one. Probably could be any one of you. Renee, want to jump?
Well, I think first and foremost is just recognizing that connecting climate change to the personal health impacts that patient in front of you is experiencing, or the very mission and job of the clinician, I mean, that makes decarbonization very personal, because it's abstract sometimes as far as we need to reduce greenhouse gases, but what does that actually mean? But if we can center the patient and the clinician relationship and within the broader health system in our communities, and really look at it from that local level and meet that person in front of you wherever they are, that's how all of that upstream action suddenly becomes reality. And I think it's been said before, but this isn't about polar bears and icebergs. And so I think, but we have to be able to equip and work collectively to equip every individual clinician and every patient with what they need. And we can only do that with speed and scale by working together.
I would just add too, specifically in the context of what a health professional can do in their own organization, we have lots of examples of hospitals across the country where it was the effort of one or often many health professionals who really rallied inside and said, hey, leadership, we really want to see a meaningful climate commitment publicly made. We would like to see you sign on to the HHS pledge. We'd like to see, a sustainability office created. And that kind of rallying of sort of inside, I'm just now talking specifically about inside the four walls of the hospital, can be really powerful. And we've seen that sort of move institutions. It's perhaps obvious, but clinicians are, usually the largest component of the workforce of a hospital. And so kind of really organizing to influence and provide feedback and pressure to leadership can be really, really powerful. And we've seen examples of how that's kind of driven some of the kind of change that we've seen at institutional level. And that's, of course, in addition to kind of the patient pieces and then obviously what can be done outside of the four walls. But I wouldn't discount the role and the influence of clinicians in their own institutions to really say that this is an important priority for them as the workforce of that entity.
There's an old saying that where you stand depends on where you sit. And I was hoping Emily would talk about one of the great things I think Healthcare Without Harm has been focusing on. That's channels of engagement. And I didn't enunciate that specifically, but you heard that there was one group, clinicians in particular, that are very moved by mission. That's why we're in healthcare. And I'm not saying that administrative leaders aren't. I'm just saying it's an incredibly challenging moment, workforce, finance, et cetera. But those clinicians are absolutely essential to the operations. And so I think the individual clinician can express through their voice the importance and connect to incredible public policy programs, the team initiative that CMMI has put out. Congratulations, Liz, and thank you for your leadership on that, and really help to articulate both the pragmatics. You want clinicians, this is what you have to do. I realize the plural of anecdote is not data, but I want to tell you a story about a prominent health system, very name brand health system, their #1 draft pick for neurosurgery. Interviews. At the end of the interview, this fellow who they desperately wanted asked a question to the chair. He said, Chair, what is your policy on environmental sustainability? Answer, I don't know. Response, I don't think this is the right program for me. So this is very real, and we can make a difference.
Thank you. Are there any questions online? So we'll take one more, if that's okay. Yeah.
Well, thanks for the great panel. David Urbanos from Deloitte. I saw synergy on this slide and figured the consultant had to ask a question. I love the discussion around collaboration and partnerships, but I also think part of the solution is changing the basis of competition in the industry to actually win on creating more equitable and more sustainable health outcomes. And so I'd love to hear from you how you're thinking about balancing the demand and the need for collaboration with the reality that real change in this industry means competitive behavior.
Well, I think the anecdote you gave, that people are asking about it, that this becomes something that people talk about. I mean, I'm inspired by the next generation because they're asking these questions, and I think that is, if that becomes an element of competition to get workforce to succeed, if we start putting out online who's successful in their reporting, the more that we can lift up these issues and put them on par with the other commitments we've made to health equity, the other commitments we've made to increasing value, to improving quality. Maybe it becomes more integrated in the language we talk about in terms of what success means. Maybe eventually it becomes part of the financing, and that's what people try to compete on because it does mean extra dollars. I think we talked in one of the working groups this morning, it's a pathway, but we got to start somewhere. So we start with carrots, and then maybe at some point it becomes sticks, but at some point it does become an element of competition and ingrained in how we do things.
I would add a dimension to that, which is that when you have large systems beginning to say, this is where we are going, that creates its own kind of competition and innovation. So those who are not essentially competing effectively start to drift to the back, and I think that's something else to watch for, which is we're going to see innovation, I think, on that side too.
You know, I think there is work in this space that is not competitive, and really nor should it necessarily ever be. However, where I think competition will come in relates to some of the cost differentials, cost savings that comes from engaging in environmental stewardship. And I'll share a real life example for a moment, and that relates to the early investments that Kaiser Permanente made in renewable energy. Those early investments, you know, when there was an energy crisis related to the conflict in Ukraine, our energy prices were flat because we had made a long-term fixed price investment to cover all of our energy from renewable sources. So what does that mean? We saved millions and millions of dollars that then could be invested directly back into patient care, and that helps keep us competitive.
And I would just add, to keep it really simple, we categorize a lot of these solutions, scope 1, 2, 3, all these. I think there's really two buckets. There's things we know how to solve for, and then there's things that we're still figuring out, and a lot of, you know, kind of product level emissions, right? Like, there's a lot that we still have to figure out. On all of those things, we already know what the solutions are. There should absolutely be competition, standards, carrots, sticks. Everyone can meet that level. And then there's a whole host of things where a lot of it's in the supply chain, and Seema talked about that initiative. We're kind of figuring it out, and that's going to take that collaboration. So a really simple, maybe overly simplistic sorting is just, what do we know? We know the solutions, we have them, we can implement them today. And then some things where we still have a lot of innovation that has to happen, and that should be collaborative.
I know we're out of time, so I want to thank the group for bringing to life this discussion about collaboration. Appreciate it.
Thank you.
While they're taking the seats, what a great panel. I agree with many of the comments. Lots of collaboration needed, and sometimes when you know what you're supposed to measure, competition is not bad. Certainly we see that everywhere.